So welcome, Ramani. Thank you very much for joining us today. Ramani got so much to her CV, but I'll just quickly run through some of the major things. Ramani is a clinical scientist and health service leader, and she has a clinical background in anaesthesia, perioperative and critical care medicine. Her research focuses primarily on improving outcomes from surgery through delivering better quality care, addressing health inequalities and improving patient safety. She was awarded the Honour of Officer of the Order of the British Empire, the OBE, in 2021 for services to healthcare. Some personal information: she's married to an infinitely patient inventor and lives with him and their 3 adopted children. That must be a busy life in the Sussex countryside, surrounded by sheep. Thank you. That gives us a feel of your life outside of work, Ramani. And as I say, we're delighted to have Ramani today, and she's going to deliver our SafetyNet seminar for us. So over to you, Ramani. Thank you.
Thanks so much, Rebecca. Really delighted to be here. And thanks, Sobia, for organising this as well. So I will now share my screen and just do having got the slideshow all beautifully set up before. Let's see if I can do that. Is that showing a proper view, Rebecca? Is that okay?
I think that's presenter view, Ramani. We can see the slides coming up.
Let me just give me 1 second. I had it done
No,
perfectly before. And let me just try one more time.
That's perfect. Thank you.
Okay, brilliant. Thank you. So thank you very much, Rebecca and Sobia, for the invitation to talk today about a programme of work which is NIHR funded, and we're about 18 months into now, that really arose from an observation in my clinical work where I commonly see people who are high risk awaiting major surgery, that I felt that there was a socioeconomic divide in terms of their risk factors, their likelihood of a good outcome, and really the tools with which I was equipped to try and help them as a clinician. And so that's where this project has originated from. And it's grown into a programme grant which NIHR funded and started last April. So the overview of the programme of work is here. So what we're trying to do is to improve outcome. The programme's called HIPPOCRATES, which is health inequalities in perioperative care, creating targeted interventions. And the idea is to improve outcomes and reduce health inequalities for people living specifically with socioeconomic deprivation, having major non-cardiac surgery. So you can see here a standard sort of PICO description of what we're trying to do, where the population is people living with socioeconomic deprivation, having big operations with an expected length of stay of at least 3 days. To put that into context, the NHS does about 10 million operations a year, of which about 80% are done as a day case. About 15% of operations would be classified as high risk on the basis of either the magnitude of the surgery or the patient's long-term conditions or other risk factors. So it's that group of patients that we're trying to impact on here. And what we're trying to do is co-design with patients and public from our target audience, if you like, 3 complex interventions, compare them to standard care, and improve post-operative morbidity and mortality. And I'll explain more about the measure DAOH 30, which is days alive and out of hospital at 30 days as we go on. So you will have seen graphs like this before. This comes from government statistics and shows here that deprivation, which here is represented by different lines on deprivation deciles between 1 and 10 on the x-axis of these graphs, and geography matter in terms of healthy life expectancy and life expectancy. So what you see here is the most deprived group is IMD quintile, or index of multiple deprivation quintile number 1, on the left-hand side of each of those graphs. and the least deprived, most affluent people are represented on the right-hand side. And you see two things here. So first of all, there's a clear gradient, both in terms of healthy life expectancy for both in terms of life expectancy for both men and women, men at the top and women at the bottom. But the second thing that you see is a geography difference. So these graphs compare London in green with the northeast in the dark green. And you can see there a huge difference in life expectancy, even within a single IMD decile. So if you look at the top graph, the most deprived group in IMD decile 1, where in the northeast life expectancy is around 72 years, and in London it's around 75 years. You will know, I'm sure, that between the richest and the poorest areas of the UK in general, so between Glasgow, the poorest area of Glasgow, and the most affluent area of Surrey, there's a 17-year difference in life expectancy. And in fact, the NHS is increasingly focused on healthy life expectancy as a target for improvement. So it is what underpins the 10-year health plan for England, is the ambition to improve healthy life expectancy, and all of the stuff that we're doing to do with quality in the NHS is in the end is fundamentally trying to address healthy life expectancy. Now, in the case of surgery, which is my area of interest as an anaesthetist and an intensive care doctor, we see the same sorts of patterns. So these are two papers that we've published. At the top left is some analyses of long-term outcome, so 3-year outcome after planned surgery. And on the bottom right, a graph which shows short-term outcomes, so 30-day mortality after emergency abdominal surgery. Elective surgery, overall population mortality is about 1% at 30 days. But what you see there in that top graph is, again, a big difference between the richest and the poorest in terms of their survival probability going all the way out to 3 years. And on the right-hand side, you see an odds ratio graph where you see the most deprived group on the right-hand side there, who are significantly more likely to die within 30 days of their emergency abdominal surgery. And in both of these cases, this is after accounting for other risk factors like heart disease, lung disease, and so on. So what we're trying to do in this programme of work is, through multiple different work packages, follow a trail. So first of all, to establish the epidemiology, to generate hypotheses about things that might work. If you are familiar with Michael Marmot's work and his assertion that health inequalities related to socioeconomic deprivation are largely determined by the social determinants of health, such as poverty and education and housing and all of those things. I don't deny that. I think that's fundamentally true, of course. But of course, we wait endlessly for governments to make a meaningful difference to those things, and we see that not happening. So where we have a sort of captive audience, if you like, where patients are coming for planned surgery, there may be an opportunity to address these inequalities in a short-term way, and that's what this project is trying to do. So first of all, we want to do some epidemiological analysis to generate hypotheses about what might work. Then the plan has been to do co-design to establish, first of all, through establishing the evidence for what might work, seeking expert opinion to build on what we found from the literature, and then to undertake a process of user-informed design, iterative design, to develop program theories and co-design interventions, complex interventions that might work for these patients. And then the plan is to pilot these in a platform randomized controlled trial where we can test all 3 interventions against a single control group, where we will assess the feasibility, acceptability, and fidelity of those interventions. And then finally, to take at least one through to a full trial, where we will evaluate the clinical and cost effectiveness. So that's the programme of work that is Hippocrates, that is 6 years long. And what I'm going to talk about today is the outcomes of the first 2 work packages, which are the epidemiology and the co-design. So for the epidemiology, we used 2 large data sets that we already had access to. So the first was a study called SNAP2 Epics, which took place in 1 week in 2017, where we went out to 94% of acute NHS providers for a week and asked them to give us data on all elective and emergency inpatient, so overnight stay, non-cardiac surgery, And really importantly about the methodology of this study was that it was an opt-out consent for patients. So we got as unbiased a sample as we could of what was going on in the NHS in that week. And we generated a data set where we had nearly 19,000 patients with inpatient outcomes censored at 60 days. And then a slightly smaller data set, where we linked prospectively collected data from hospitals with NHS routine data, so hospital episode statistics and the Office of National Statistics mortality register. And we got just over 15,000 patients in that group. And the second large data set that we've looked at is that collected through a cohort study called PQIP, or the Perioperative Quality Improvement Programme, which has included over its time 171 NHS providers. It's different to the SNAP2 study because it's consenting patients only, so there will be some recruitment bias in there. And it's also only elective major surgery, so we didn't include any emergency surgery. But it's a very high risk cohort, the same sort of cohort that we're trying to impact on in Hippocrates, with a median length of stay of 6 days. And we were able to collect a much more detailed data set in PQIP in nearly 56,000 patients that we were able to analyse for this study. And included in that data set was individual measures of deprivation, such as the patient's individual educational attainment and their individual housing circumstances, for example. So presenting some interim results, and I've got a few photos of some of the team that have been responsible for delivering this work. So Ema Lusby is the lady in the pink hat at the bottom there, who's an anaesthetist resident doctor, who led this analysis and wrote the paper alongside Bo Howe, who's one of our statisticians, and Snehal Pinto Pereira, who's our senior statistician. And what you see here is confirmatory evidence of our hypothesis, which is that, first of all, patients in the most deprived IMD quintile, so the most deprived 20% of neighbourhoods, are more likely to die within 30 days if you just look at their unadjusted data, so unadjusted for other risk factors such as age and so on. Then, if you look at the second graph at the bottom there, if you adjust that data for fixed factors, so things that you can't change, like your age or your sex, you can see that that impact gets even bigger, and you start to see an impact even of the patients in the next most deprived 20% of neighbourhoods. You see the same sort of pattern when you look at inpatient morbidity, so complications after surgery. So again, people living in poorer neighbourhoods are more likely to suffer inpatient complications. And then if you adjust for those fixed factors like age and sex and type of surgery, that relationship becomes more pronounced. But here's the really interesting thing, is that if you chuck in potentially modifiable risk factors, so here we're talking about things like your control of your long-term conditions like diabetes or anemia and that kind of thing, then that impact disappears. And so what that does is it gives us a bit of hope that if we can intervene in the preoperative setting to get patients fitter before their operation, that we might have a chance of addressing that health inequality related to socioeconomic deprivation. So our second analysis was looking at shorter and longer term outcomes from the PQIP study. And this analysis has been led by James Durrand, who I think is on the call, who's a resident doctor based in South Tees in Middlesbrough, and has been working with our team on fellowship. And so we found in his analysis of PQIP data, again, that we have outcomes that are attenuated, so outcome differences in the short term, so short-term inpatient morbidity, 30-day mortality, and then days alive and out of hospital at 30 days, which is basically a combination of whether you lived or died by 30 days and how many days you spent in hospital, which is a sort of surrogate for complications. Now, all of these were worse for people living in areas of socioeconomic deprivation, despite the fact that on the whole they were younger. And that fits with the data that I showed you earlier, that people die prematurely if they live in poor areas. So biologically, whatever their chronological age, their biological age is older. And we see the same signal both in mortality at 365 days and also in the days alive and out of hospital there. But really importantly, there's hypothesis generating stuff that's come out of this analysis. So people living in the most deprived neighbourhoods in the PQIP study, this follows what we know about people in the general population as well. So despite being poor, they're more likely to smoke, also less likely to be offered smoking cessation therapy preoperatively. They're more likely to be obese or living with severe obesity. They're more likely to have higher ASA grades. The ASA grade is a measure that anaesthetists use to basically give a simple assessment of overall health and fitness. They're more likely to be presenting with advanced cancer. We know that access is a big problem in people from deprived socioeconomic backgrounds and also from some ethnic minority groups. So they're presenting for surgery at a more advanced stage and therefore less likely to have a good outcome. They're also more likely to be inactive, and they're more likely to have challenging social circumstances, such as they are less likely to own their own home, they're disproportionately facing unemployment, disproportionately responsible for others, have more blue-collar occupations than white-collar, and less educational attainment. So all the things that you would expect are there, and they're there importantly at individual level as well as at postcode level, which is what the IMD quintile gives us. So that then leads us on to thinking, well, can we therefore intervene to get them into better health? Because we think that there is a mediator between being in a poor neighbourhood and having a poor outcome from surgery. That is your cardiorespiratory health and your long-term fitness and long-term conditions. Can we offer financial support or physiological improvement to try and address health issues before surgery? Can we look after them differently after their operation in order to reduce the risk of a complication occurring at all or potentially becoming a death? And how do we improve uptake of the things we know work? Because there are plenty of interventions that we deploy in the NHS already to get people fitter for surgery. What we know is that the uptake of those things in people who are poor or people who have other protected characteristics is worse than in people who don't. So how do we improve uptake? And that's where the co-design comes in, because the hypothesis and the aim is really to, if we know what should work, then if we can co-design interventions that are valid to clinicians and scientists, but acceptable to patients and public from these deprived socioeconomic backgrounds, then we think that they will be more likely to be acceptable and accessible to those service users, and therefore they're more likely to work. So the objectives of our co-design work have been to identify, first of all, the key ingredients of the three complex interventions that we sought to develop. And I'll come on to what I mean by that in a minute, but we do that through literature review and talking to experts. The second is to define user experience expectations and identify potential challenges for co-design, develop materials to support, prepare and build trust with patients and public prior to co-design, and then use co-design workshops to develop programme theories for each of our interventions. So the three candidate complex interventions that we identified before we went as part of the grant application, before we went into the programme, are listed here. So the first is comprehensive preoperative preparation and optimization, so getting people fitter for surgery. And that's a combination of things. That's long-term condition management, so if they've got diabetes, making sure it's well controlled, if they've got anemia, identifying it and treating it. Health behaviour management, so if they smoke, offering them smoking cessation therapy and actually getting them to stop or reduce their smoking, their tobacco intake. And then this complex intervention called prehabilitation as a sort of as a shorthand, but essentially it comprises three components. So improving cardiorespiratory fitness through exercise, improving nutrition, which is predominantly based around identifying patients who are malnourished and appropriately treating them, but for all patients, potentially boosting their protein intake, because major surgery is intensely catabolic. So you use a lot of energy and you eventually drill down into your protein supplies. So if you don't have much protein, then you're at high risk of a poor outcome. And then finally, psychological preparedness. So identifying patients who need specific interventions, but also possibly for all patients, offering things like, for example, interventions to improve their levels of patient activation, their levels of health literacy in order to try and improve compliance with the rest of what we're trying to do. So that's intervention number one. Intervention number two is financial navigation and support. So can helping people to understand what they're entitled to in terms of benefits, for example, and possibly offering a small cash grant or a small grant in some way, support them in terms of navigating the complexity that is having a big operation. And I'll come on to talk a bit about the detail of what we found in co-design. It's very interesting about that one. And then finally, the third intervention is post-operative enhanced surveillance. So looking after people more closely and differently after the operation, both as an inpatient, but also after they've been discharged from hospital for the first few weeks after they've gone home. This is a schematic developed by Alison Thompson, who is a reader in design at QMUL in London, and she has led the co-design aspect of this work package alongside Cecilia Vendrola, who's our Professor of Medical Anthropology and Rapid Research, who's led the qualitative aspects of this co-design process. So we're following the Design Council's double diamond approach, which you can see there on the bottom left. There's nothing kind of particularly earth-shattering about the double diamond approach. What it is iterative design, which all designers would kind of say is the way they do things. So you can see here the process that we've gone through, starting with systematic literature reviews, then initial scoping discussions with experts that we sourced from around the country and internationally, development of co-design materials to use in the workshops. And for that, we worked with a commercial company called the Agency of Design, who've worked with Alison before to develop these materials, which you'll see is a cut above anything that I could certainly do as a clinician as well. And then a series of co-design workshops for each intervention where we take the patients through the pathway and work with them to understand what would meet their needs. We then had constructive discussions around an equity rubric, which was led by Professor George Black from QMUL as well, and Professor Dr. Sami Quaife. So checking in about the equity of all the interventions that we were trying to develop, not just from the perspective of socioeconomic deprivation, but also from other sources of health inequalities. And then finally, developing materials that would support the implementation of these interventions that we are co-designing. So the team you will see here for this particular work package, so Alison, who's a design-led researcher, the Agency of Design, as I've mentioned, subcontracted to do some of the work with us, Cecilia leading on the rapid qualitative methods that we've used, 3 PhD students, so Cyril Clark, Adam Hunt and Katie Gilchrist, Katie also being our PPI lead for the overall programme of work, so all doing qualitative-based PhDs on the Hippocrates study, and then Georgia and Sami supporting us from the equity rubric perspective with their backgrounds in sociology and behavioural psychology. Now, one of the great joys of this project for me has been working with Community Organisers, which is a charity, and talk about serendipity. I discovered that they existed through chatting to a mum on the school run who's a friend of mine, and she mentioned that she was the ops manager for this charity that basically coordinates activities in social action hubs across the country. So the social action hubs work in local communities. Community Organisers has a network of these where they can facilitate code, all sorts of different things, but basically getting people's voices into policy and so on and so forth. So we contracted them to help us reach into communities that we would have otherwise found difficult to reach. You see on the right there one of the participant information sheets that we used to inform people of the study, designed by the Agency of Design in a much nicer way than I would have ever been able to do. So we've really benefited from expertise from a broad range of disciplines for this. We've actually done 12 workshops now, but here are some of the places that we've been to. So Birkenhead, Haringey, Salford, Luton, and various places in London. And 3 workshops on each of the 3 interventions that I've covered the highlights of. The way that we've done it is, so the Agency of Design developed storyboard cards, walking people through the patient journey from the perspective of each of the 3 interventions. And the personas that were developed for each workshop were different depending on where we were going. So the workshop in Birkenhead, near Liverpool, everybody that attended was white. There was a lot of younger people there, young women with children and so on. The workshop that I attended in Tottenham in Haringey, there wasn't that the only white people in the room were the guys from the Agency of Design. So you can see that they're at different contexts demanded different, more culturally appropriate storyboards, and that's what the guys did here. But the basic story was the same across the board. So here you can see Mark's story here, which is of somebody who is waiting for surgery, and this is the storyboard that we use to support the financial support workshops. So the idea that this chap was preparing for a big operation where he was going to have a bowel cancer removed, and his costs were piling up. He was unable to find the money to get to appointments. He had to stop work in order to attend different appointments and so on and so forth. And so it paints a rather gloomy story of what happened to Mark. And you can see here the different ways in which the team portrayed that for the different cultural backgrounds, but telling the same story. And then what the team did was then interject with cards like this to try and show how things could potentially be different. So here, offering from our literature review and our talking to experts, things that we thought could potentially work. So trying to, in the case of the financial support intervention, directing the patient towards citizens' advice in a timely way, getting help to enable them to fill in forms for different benefits that they might be entitled to, and possibly offering them a small grant to help them tide over, because often it can take weeks, if not months, for benefits to come through, even if the patient is entitled to them. And then the analysis, so after the workshops, which tended to last about an hour and a half, with a bit of chat at the beginning, introducing ourselves, and then workshops with a researcher or a member of the agency design sitting at each table, facilitating the discussion with these pitch cards, refreshments provided for the people that attended. We also offered a financial payment to people that attended for their time. And then afterwards, an immediate debrief in a local coffee shop, development of real sheets, which is something that Cecilia and her team, the Rapid Research Evaluation and Appraisal Lab, have developed, which is a rapid research methodology for taking notes quickly and informing program theories, iteration of the concepts and the materials for the next session, and then iteratively on from there. Towards the end of this process, we're now in the process of sense checking what we've come up with experts and the pilot sites that we hope that will take part in our pilot RCT. So I'll give you a bit of a readout of what we've found. So for the financial support intervention, which we kind of pre-decided would be short-term financial support for patients before and or after major surgery, which may take the form of cash or vouchers. So our systematic literature review found in general that there was very little evidence to support this type of intervention in the UK. Where there have been financial support interventions, they've either been in low and middle income settings, or in places like the United States, where they have a different structure for their healthcare system. And so the contexts are really quite different. So we went for these workshops to Birkenhead, Haringey and Pimlico, and included about 40 participants overall. I've shown you this already, which is the storyboards that we use. This is a picture of one of the workshops. You can see Siren there on the right-hand side, one of our researchers. Key conversation points that came up. So first of all, the cost of surgery. Even though we provide the service for free, there is a cost attached to having surgery. You have to get to the hospital and back. Transport is a major financial challenge, and that was replicated across the board. It was the same whether people were in Birkenhead or London, where there's an excellent transport system. So transport is a big financial challenge. Major distrust of GPs, which was interesting. Certainly from a healthcare perspective, we're constantly trying to, you all know about this left shift that we're trying to promote neighbourhood health and so on through the 10-year health plan, but something that came through time and time again is that people have become disillusioned with primary care, and then somehow when they get into secondary care, it's a different relationship and a new one that might potentially have a better opportunity for a trusted relationship. People lie on the phone, quite an interesting thing to come out that I hadn't necessarily anticipated, that it's harder to lie if you're actually facing someone, even if it's over a screen. And the reason that that's important for this one is that people are proud. They don't want to ask for help. And so if you ask them if they need help, they might just say no, even if they don't. So probably the right approach to help people is that to offer this as an opt-out as opposed to an opt-in. You are going to see someone from Citizens Advice unless you don't turn up, and in the nicest possible way. The prehab intervention, which is trying to identify health challenges and improve health and fitness, including long-term conditions, behaviours, health-related behaviours, and exercise, nutrition, and psychological support. 3 workshops, again, 2 in London and 1 in Luton. Very diverse audiences in these different workshops. The one in Luton I wasn't able to get to, but the place to me just sounded amazing. This is the living room at the bottom of a tower block in Luton, where they had this social action hub, and so everyone that attended was a resident of that tower block. Interestingly, you can see an exercise bike there at the back, which I think is basically unused. Here they went through Linda's story, talking about opportunities for her to engage with exercise sessions using, for example, videos, or potentially going to an exercise class in a different set of options, and so on. The key conversation points and things that came up that surprised us. So if you look at the way that we deliver prehabilitation in the NHS at the moment, everyone is very focused on the exercise bit because it's the bit that we know definitely works. If you are unfit, you are more likely to get a post-operative complication. So if you improve your cardiorespiratory fitness, you are less likely to get a complication. So all of the energy from a healthcare perspective goes into getting people to exercise. But what the patients and public told us is that psychological support needs to come first. And of the triumvirate of exercise, nutrition, and psychology in prehab interventions, psychology is definitely the one that is neglected. So lots of places don't even do psychological screening at all, and hardly anywhere offers anything to people unless they are right at the bleeding edge of really, really having a terrible psychological profile, and therefore needing to see a clinical psychologist or psychiatrist to help them. So there's very little that we offer to people who are less severely affected by mental health issues. And of course, we know that access to mental health services is a real challenge for everyone. The second thing that came out, which is kind of bland or obvious, but it's not, again, something that we do very well in the NHS, is about giving people choice. So saying that the only way to be able to access an exercise class is to turn up at 2 o'clock on a Wednesday afternoon is not what the patients want to hear. They want to have an option of how they do it, when they do it, and so on. That's critical. But with that, we also need to inject a bit of realism, which is if the patients say it's okay, I'll do it on my own, we know from the evidence that that doesn't work, because we're all the same. If I'm supposed to go to the gym tonight, I often won't do it. So there does need to be a way of how we support people through the process to actually comply with the exercise interventions, even if we give them a choice about how to do it. And then finally, the post-operative surveillance intervention. So how do we look after patients differently after surgery? For this, we went to Manchester, to Salford, to Luton, and to Islington. The storyboard card here is about how the patient is looked after, how she went home and then realised that something wasn't right and ended up back in hospital because she wasn't able to access timely advice. And then we interjected with lots of different ideas about how we could keep in touch with people using apps, for example, or text messages, or using, on the right there, physiological monitoring, particularly while they're in hospital, so continuous monitoring with a wireless wearable. So key conversation points. This, from an NHS perspective, was interesting to me because we've got this constant drive towards digital, but actually people want SMS messaging, not an app. That works. Not even WhatsApp. They would prefer SMS messaging. there's the opportunity that even if the patient themselves isn't very good with a mobile phone, that a family member or significant other person could help. There was a lot of discussion about the challenge of actually being able to respond after surgery, and the whole kind of I don't want to trouble anyone context, which we know is a barrier to people accessing help. So again, being proactive and us reaching out to them as opposed to expecting them to reach out to healthcare is a key kind of defining principle. And then finally, the need for the human touch. It's fine to do light touch contact with a text message, but it needs to, if the patient is in need, it needs to be pretty quickly followed up with the human touch. So reflections from the workshops. It was brilliant working with community organisers. The team came back really energised from all of the sessions, and that's been a really fantastic relationship that we've built there. We were able to get people there because remuneration for time and a demonstration of appreciation through a small financial gift was well received and was administered through the people working in the social action hubs. So through trusted people, not us giving them the money, it was the people from the social action hubs giving the people that attended workshops the money. And then the complexity of people's lives. And of course, that's the sort of big thing here is that people who live in positions of financial hardship are they have much more going on probably than the rest of us. And so that has a big impact on the likelihood that they'll be able to comply with interventions that we want to introduce to try and improve their surgical outcome. We do need the injection of reality. We had lots of patients say, yeah, I'd love to go to a dance class. I'd love to do this, I'd love to do that about the exercise interventions. But we have to keep coming back to the fact that unless you get your heart rate up, unless you get sweaty and breathless, the exercise isn't likely to actually have an impact on your cardiorespiratory health. And so we need to sort of combine the two. So here's where we got to with our pre-op optimization intervention, where we're going to screen patients for long-term conditions, health behaviours, psychology, exercise status, and nutritional status, and then essentially triage them into 3 groups depending on the outcomes. And they might be in different groups for their long-term health versus their nutritional health, for example. But 3 things that we know that we're going to try and do across the board. So the first is try to give clinicians access to better ways to talk to people, better ways to have good conversations. So motivational interviewing and health coaching for clinicians that have these conversations with patients, so that there's a better chance that patients will accept the interventions that are being offered. The second is trying to make things as easy as possible. So protein shots, for example, rather than trying to change people's diets in this short-term intervention in the run-up to surgery. And then the third is about offering choice about how people do exercise. So we're probably going to try and set up a contract with a commercial provider to give the patients access to classes, as well as provide online live classes that patients can join online if they would like to. The finance intervention is looking like this. So an approach by a trusted person who would probably be the clinical nurse specialist in the hospital, who will maintain a relationship with the patient throughout. An opt-out approach to advice, which would come from Citizens Advice, with whom we will set up a contract. Probably a national coordinator that would then do a video call with the patient to understand their needs, and then local advice, which would include completing forms and access to specific support that's available locally. And then probably a small unrestricted gift. The unrestricted bit is important. There's a reasonable amount of evidence that if you try to control what you give people, it doesn't have the same outcome. We do have a small counter challenge with that around potentially people who have addiction problems, and also potentially people who are under coercive control. I think these are minority issues, and I think that probably a cash transfer is best, but the logistics of being able to do that is also challenging. So we may have to end up going for food vouchers, because obviously everyone needs to eat. And so just providing some food vouchers may release income for them to be able to use in other ways as well. And actually, really importantly, offering people advice with how to access cheap transport and compensation for transport costs is really important for this. And then finally, the post-op surveillance intervention. So a wireless wearable monitor from the time the patient leaves the operating room while they're in hospital and for 2 days post-discharge. We're going to probably use this monitor called the checkpoint cardio, which gives heart rate, blood pressure, respiratory rate, and so on, and sends a signal to a nerve centre in Bulgaria, of all places, which then return a message to clinicians in the hospital if they're concerned about the patient. And then from the first day after surgery until day 30, whether they're in or out of the hospital, text messaging to ask a simple question like this: how are you today? Better, worse, or the same? And then, depending on the responses, a response which might lead to a phone call and potentially bringing the patient back in. So we're going to take these interventions. We're just finalising our protocol for the study and submission to ethics. The 3 interventions will be tested in a platform study. The primary outcome being days alive and out of hospital at 30 days. We're going to recruit in 12 different hospitals across England. And we will then undertake a mixed methods evaluation, which will look at not just the data like compliance and so on, but also patient perceptions, clinician perceptions, acceptability, fidelity, and so on. And then we will move on to a full randomized trial with the intervention that looks like it is the most promising, which will include a health economic evaluation. So that's where we are now, and aiming, probably a bit ambitiously, to start recruitment in October of this year. We are on track for submitting our ethics next month, though. So I'm going to stop there, Rebecca. It's a big team involved. Here are some of them, and I will now say thank you to them and hand back to you. Thanks.
Well, thank you so much, Ramani. What an amazing presentation.